Welcome to this video on pediatric bronchial asthma. Our learning objectives for this video include defining asthma, explaining its pathophysiology, recognizing clinical features and triggers, and outlining management strategies based on age and severity. Asthma is one of the most common chronic childhood diseases, leading to significant outpatient visits, hospital admissions, and school absenteeism. It is important to remember that many exacerbations are preventable. Asthma is a chronic inflammatory disease of the airways, characterized by variable and reversible airflow obstruction and bronchial hyperresponsiveness. The clinical picture of asthma includes recurrent wheezing, night or early morning cough, breathlessness, and chest tightness. Common triggers for asthma include viral infections, allergens, exercise, cold air, and smoke. In young children, viral infections are the most common trigger. Physical examination findings often include expiratory wheeze, prolonged expiration, tachypnea, and accessory muscle use. Wheeze is a high-pitched whistling sound on expiration. Signs of severe or life-threatening asthma include an inability to speak or feed, severe distress, a silent chest, or oxygen saturation below 92%. These require urgent management. Severity assessment includes looking at speech, respiratory rate, RR, and SpO2. Mild cases have normal speech and SpO2 of 95% or more, while severe cases involve speaking only in words and SpO2 under 92%. The pathophysiology of asthma involves airway inflammation due to the interaction between environment and genetic factors. This leads to bronchoconstriction, mucus hypersecretion, and airway edema, resulting in airflow limitation. The diagnostic approach to asthma is based on episodic symptoms, reversible airflow obstruction, and the exclusion of alternative diagnoses. When diagnosing, consider questions that rule out foreign body aspiration. Asthma is a diagnosis of recurrent episodic symptoms characterized by symptom-free intervals. Persistent or continuous symptoms require consideration of an alternative diagnosis before initiating long-term steroids. Airflow obstruction in asthma is reversible, meaning it improves dramatically with bronchodilators, nebulization, or oral steroids. Fixed obstruction suggests other pathology and a poor response to treatment. Differential diagnoses of wheeze in children include bronchiolitis, pneumonia, foreign body aspiration, congenital airway anomalies, and cystic fibrosis. Asking key questions about onset, growth, and feeding can help differentiate. Clinical features that suggest an alternative diagnosis to asthma include persistent symptoms, failure to thrive, clubbing, focal chest signs, and poor response to treatment. The approach to pediatric asthma is age-based. For children under 5, viral-induced wheeze is common. In those aged 5 years and older, a classical asthma pattern is typically seen. Diagnosis and treatment strategies differ between these age groups. For children under 5, the diagnosis of asthma is clinical and probability-based, relying on recurrent wheeze episodes. Spirometry is not reliable at this age. Improvement with a trial of a bronchodilator or inhaled corticosteroids supports the diagnosis. In children aged 5 and above, diagnosis requires objective confirmation, not just probability. This includes clinical history and physical examination, followed by objective testing like spirometry to confirm reversible airflow obstruction and fractional exhaled nitric oxide testing. Long-term management for children under 5 starts with as needed, or PRN, short-acting beta agonists SABA, via a pressurized metered dose inhaler with a spacer and mask. For more frequent symptoms, move to regular daily low-dose inhaled corticosteroids, ICS. The management for children under 5 follows a step-up approach, starting with as-needed SABA, then daily low-dose ICS, and eventually doubling the ICS dose or adding LTRA. Steps represent the level of medication needed for control. For children aged 5 and above, a 2-track approach is used. Track 1, the preferred option, involves an anti-inflammatory reliever approach, using ICS formoterol for both relief and control. This strategy is also known as MART, or maintenance and reliever therapy. Track 2 is an alternative, using the SABA reliever approach. This requires regular ICS to reduce risk. Crucially, SABA should no longer be prescribed alone, and a dose of low-dose ICS must be taken whenever SABA is used. Inhaler technique is vital for effective treatment. Key steps include preparing, priming, positioning, actuating, and breathing with the spacer. Always use a spacer with a metered dose inhaler in children. Prevention is powerful. Adherence to medication, even at 80% of prescribed doses, significantly improves outcomes. Using a PMDI with a spacer is mandatory for pediatric patients and effective in acute settings. Education on inhaler use is a powerful intervention. Patient education is crucial. Parent education is vital due to cultural myths surrounding inhalers. A written asthma action plan, or WAAP, is a mandatory component of standard care. The WAAP has 4 essential elements: daily medications, early warning signs, specific dosing for worsening symptoms, and instructions on when to seek urgent care. A written plan reduces hospitalizations and empowers parents to act immediately. Thank you for watching this video on pediatric bronchial asthma.